There were dysynchrony between the patient and the ventilator, and this is what I'm going to briefly describe. These are the companies with which we have been lucky to work for getting some equipment or some funding for research grants. So I'm very grateful to these companies, and you will have to decide whether this can influence my judgment. This is what we call conflict of interest. So a number of years ago, we did a prospective study where we look at all patients under assisted or partial ventilation in the ICU and look at the frequency of asynchrony. And we found that approximately 1/4 of the patients had a large number of asynchrony. Arbitrarily, we define this using an asynchrony index, which is a number of breaths which are completely asynchronous with the ventilator. And we found that there was a very clear association between a longer duration of mechanical ventilation, as indicated on this graph. And despite the fact that these patients were not particularly more severe, there was a tendency for having more COPD in this group, but gas exchange, tidal volume did not look worse. So there was specific associated with asynchrony and poor outcome, and we reasoned that maybe there is something to do better in delivering ventilation. This was confirmed in other study in the ICU. This is study by Marjolaine de Witt, who found approximately the same incidence, the same association with long-term outcome, with duration of mechanical ventilation, even when using a multivariable model adjusting for severity factors. And the group of Louis Blanc, who Louis will deliver a lecture after me on monitoring asynchrony, even found that there was a significant association with mortality. Do all asynchrony matters? We don't know yet. There are different types of asynchrony which have been described. But recently, Dimitris, our chairman, made an important observation saying that, well, maybe having one asynchrony from time to time, and they focused here on ineffective efforts, may not matter so much, but having what they call clusters of asynchrony, and they illustrate here the you see here the time scale where you have occurrence here of a large number of asynchrony over a relatively short period of time. These clusters of ineffective effort, which they called events in this study, were those specially associated with poor outcome. You see the association with a longer duration of ICU stay, longer duration of total minute mechanical ventilation time, and especially the time after the start of the weaning period. So, and of course it makes a lot of sense, so they gave a definition of this cluster, and it's a step forward causality between having asynchrony and having a poor outcome, because it makes more sense to see that when you have a lot of asynchrony at the same time over a short period, it may have an impact on patient physiology and outcome. So what's a bit complicated today is that we tend to put all asynchrony in the same big bag. However, they are very different asynchrony which have different mechanism. And to make things a little bit simpler, not too simple, I hope, I will separate some asynchrony associated with assistance delivered in excess and asynchrony associated with assistance insufficient regarding the need of the patient. And when you deliver assistance in excess, which is very easy to achieve with pressure support ventilation, you may have apnea or you may have ineffective efforts. This is a classical example of tracings you can observe on the ventilator, where everything looks very regular and very nice, and which in fact is in reality completely asynchronous. Because if you look at what the patient is doing, and this is the electrical activity of the diaphragm and the very, very small PDI swing, you see that in fact the patient is breathing here, is doing a very weak effort. At the end of this weak effort, it's triggering the breath, and the insufflation is delivered completely passively. So it looks like a very regular and smooth pressure support assist ventilation, but it's in fact the alternance of very weak effort by the patient and passively delivered controlled breath. So it's completely asynchronous, and because it's associated with excessive ventilation, as indicated by the very low drive, it's usually associated with periods of apnea. You see, interestingly, it's not complete apnea in terms of central drive, but these efforts are so weak that they do not trigger anymore the ventilator. And these periods of apnea have been shown, for instance, for patients with, who are sleeping on the ventilator or trying to sleep, to induce repeated episodes of arousal or awakening. In this nice study by Sai Parthasarathi and Tobin, you see on the tracing of the tidal volume, for instance, the repeated episode of apnea, which were associated on the EEG pattern with repeated awakening and arousal. So if you imagine a patient always trying to go to sleep and always having this experiencing this episode of apnea and arousal and awakening, this can be terrible and, for instance, be a good reason to worsen outcome. So this is the first thing I think we clinicians should be attentive to when we see the alarm of low-minute ventilation and pressure support. In most of the cases, it's because we give too much pressure support, especially when patients try to sleep. The next thing which will happen, especially if the patient has some degree of obstructive lung disease, is triggering asynchrony or ineffective effort, which was initially nicely shown by Chow et al. In this group of patients with chronic ventilator dependence. And what you see here are the breaths delivered by the ventilator. This is assist control, but this could be pressure support. And when you look at the esophageal pressure tracing, you see every bar, vertical bar, indicates an effort made by the patient. And when you look at the scale of the pressure, it's not very, very small effort. It's relatively large efforts. And you see that 1 effort, 2 effort, and 3 effort, only the third one is triggering the ventilator. So there is a complete dissociation between the number of effort done by the patient and the assistance given by the ventilator, which is at a much lower rate. And the issue here is both timing and the amount of pressure or volume delivered. Timing is very well illustrated here. This is what you see on the vent. This is pressure support triggered by the patient. This is the flow. And this is what the patient is doing in reality. So you see the timing is not good because the patient is starting to work well before the ventilator can detect the start of the effort. And this is because there is some degree of intrinsic PEEP, not huge amount, maybe 2-3 centimeters of water. And at the time the breath is recognized by the patient has almost finished his own inspiration. Then the ventilator gives the pressure maybe to an excessive amount and an excessive tidal volume. So the combination of this desynchrony in time plus the excessive amount of pressure and volume makes that for the next effort, which occurs exactly at the same normal TIT tone for the patient, there will be slightly more intrinsic PEEP, and for this next effort, the patient will be completely unable to trigger the ventilator, or if you wish, the ventilator will be unable to detect patient's effort. So this is the cause of ineffective triggering, and it's an association with a wrong timing and excessive level of ventilation. So you can try to work on the timing. For instance, in this study, we took benefit of having the monitoring of the electrical activity of the diaphragm to try to start earlier the detection of the effort by adjusting the external PEEP, and try to better adjust the cycling on the ventilator. But this is a complicated technique, and maybe the simplest way to do the adjustment in terms of pressure and volume is simply to reduce the pressure support level, or to reduce the time of delivery of pressure support by adjusting the expiratory cycling mechanism. So in those patients who had a large number of asynchrony, we tried to see what was the best technique to reduce ineffective efforts. We tried whether adjusting PEEP was a good approach, whether optimal pressure support was a good approach, and by optimal, we just tried to optimize. I'm not saying it's the best in the world, but it was optimized. Or optimizing the inspiratory time by increasing the expiratory threshold. And we find that the simplest technique, the reduction of pressure support, was very efficient to reduce asynchrony. You see the asynchrony index, which was completely normalized in many patients. You also see that in some patients, even by adjusting the ventilator, we could not change the degree of asynchrony. So asynchrony may be related to our own settings, but sometimes maybe mostly related to patient's characteristic. So at the opposite of these two kind of asynchrony I showed you, the apnea and the ineffective efforts, you have asynchrony related to insufficient assistance. And we talk a lot about this one because we now focus our attention on this type of asynchrony occurring, for instance, in ARDS, where you see double triggering, breath stacking, and short cycles. So by under assistance, I mean that the amount of ventilation or the duration of mechanical insufflation is not sufficient compared to patients' own neural breathings. So this again would be indicated by the esophageal pressure swing. And you see that the end of patient's effort is after the end of the insufflation, which make these weird tracings or this abnormal expiratory flow pattern, if you wish, because there is still some patient's effort during the early phase of expiration. And of course, this is another patient, it then can induce a double triggering. So because the patient is still trying to get air, he may have a double triggering. And we have data indicating, for instance, that the lower the tidal volume, the higher is the frequency of this problem, and the higher will be the work of breathing performed by the patient. And then we may see this kind of tracing during assist control, where we have frequent double triggering or even triple triggering. And the reason is that we tend to use relatively high flow, short inspiratory time for patients who have high respiratory drive. So this is the best combination to have this problem of double triggering or triple triggering. And of course, if we think that 6 milliliters per kilogram is the way to go, you deliver 12 or even 18 milliliters per kilogram frequently, which may impact, again, the outcome of the patient. However, this issue is a little bit more complicated because some of these double triggering may not be double triggering, but maybe double cycling, and may be caused by phenomenon which has been described before as respiratory entrainment and which we call reverse triggering, indicating that the ventilator is triggering the muscular contraction and not the opposite. Though this is a paper which we published with Evangelia Akumianaki and Jean-Christophe Richard a few years ago, describing a series of patients with ARDS under deep sedation, in whom we found a very frequent occurrence of breath contraction induced by the ventilator. And you see here that every other breath, there is first a small increase in the esophageal pressure, indicating that the beginning of insufflation is passive, and there is an abrupt decrease in esophageal pressure, indicating a contraction. In fact, it started by an accidental observation. We wanted to observe the very early phase when the patient will start to trigger the ventilator. And we took this patient who was on pressure-controlled ventilation, and as you can see, there was absolutely no indication that the patient was triggering the ventilator. This was exactly the respiratory rate of the ventilator. We put a NAVA catheter, which allows to monitor the electrical activity of the diaphragm, and to our surprise, we found that at every breath, there was an activity of the diaphragm, which was in fact a very strong activity. But when we looked at the timing between the ventilator and the patient's effort, you see that the effort of the patient started in the middle of the insufflation. And when we modified the respiratory rate on the ventilator, we modified the respiratory rate of the patient. So these diaphragmatic contractions were not coming initially from the brain of the patient, but were triggered by some reflex after the beginning of the mechanical insufflation. And the consequences could be that this contraction increased the tidal volume. For instance, you see here every other breath there is an increase in tidal volume because of this reverse triggering. Or it could induce these double cycles, which are not double triggering, because the first one is not triggered by the patient, but the second one is triggered by this reverse triggering phenomenon. And we think this is very important to recognize, because these are very deeply sedated patients. And in these patients, there are only two solutions to avoid that. One could be to go back to paralysis. The other one would be to decrease sedation. So this would lead to a very different management compared to the classical double triggering. So this is an illustration again from a review that we did with TIFAM, where we superimpose the EDI in a patient who had frequent double cycling, and you see that it becomes obvious that the first breath is fully controlled. Then there is this diaphragmatic contraction, which triggers the second breath. And without such a monitoring like EDI or esophageal pressure, it may be very difficult to detect and to understand. And we have a number of studies looking at the impact of this desynchrony. I would like just to briefly show you a preliminary result of two studies which are ongoing. One is a study where we look at the first time the patient start to use their diaphragm, and we put a NAVA catheter at the time of intubation. And we realized that for most of the patients, the first type of diaphragmatic activity is not a normal triggering, but is reverse triggering. And in fact, this is a series of patients. I think it was shown yesterday by Ricard in the abstract. We took patients on assist-controlled ventilation. We found that reverse triggering was present in almost all the patients the first day of assist-controlled ventilation, and in 40% of the patients, so it's a very sensitive detection, but in 40% of the patients, more than 10% of their breaths were reverse triggering. So we do believe it's a very, very frequent phenomenon. And in ARDS, we think it may have an impact on outcome. So we think we may need to monitor this phenomenon and maybe to have a specific management. But for that, we are collecting data in an observational study called Breathing Effort in ARDS, the BEARD study, which is ongoing. We don't have results from this study, but we already have a lot of tracings showing this kind of typical reverse triggering, where again you see the esophageal pressure going up and then going down at the same, almost the same pattern every other breath with typical breath stacking. So whether this is associated with outcome, we don't know yet, but if it turns out to be associated with poor outcome, I think it should probably change our management. These are other examples. And as we discussed this morning about studies of low PEEP and high PEEP, you may have noticed that no one of the studies performed to date have paid any attention to this problem of asynchrony. In the ART trial, which showed a higher mortality rate with high PEEP, some investigator, I think one investigator called Marcelo from Brazil, made some recordings and found that in fact a lot of patients had asynchrony in the form of double triggering or reverse triggering, and you could imagine that this asynchrony could be much more injurious if you have already start from a high PEEP than a low PEEP. So one explanation of this negative trial could be asynchrony. So in the future, if we don't pay attention to that, we will continue to have unexplained negative randomized trial. So there are many clinical consequences of asynchrony, or clinical association, I should say, and this is why I think we need to pay more attention. This is just a long list saying that it may indicate sometimes excessive or insufficient ventilatory assistance, it may indicate dynamic hyperinflation, inadequate sedation, it may be associated with sleep fragmentation, certainly associated with errors in assessing weaning readiness. It is associated with prolonged duration of ventilation, maybe with respiratory sequelae and mortality. We need to figure out what is causal, what is just simple association, and this is a very exciting challenge for the future. Thank you very much.